All right. So my name is Michelle Rubin, and I am an advanced practice nurse as a clinical nurse specialist, and I specialize in inflammatory bowel disease my entire career at the University of Chicago. I currently work in the Department of Colorectal Surgery, and my special interest as well is I manage a J-pouch clinic. So we'll get going here. I have no disclosures. So inflammatory bowel disease today, the incidence is significantly increased in the United States. And it's estimated there's 1.7 million, but by 2025, it's estimated there's going to be 2.2 million in the United States. It's split half between ulcerative colitis and Crohn's disease. And we know that they're frequently young at diagnosis, anywhere between 15 to 30, but you can see them at a very young age. And obviously we can at an older age too, but that's the most frequent age group. Most do not have a family history. It's in all ethnicities. Most are not Jewish. I can tell you when I first started eons ago on the GI floor, and we specialized in IBD back then, there was a lot of Jewish patients and they were all of Ashkenazi descent. But now we're seeing it in all ethnic groups. First generation Americans are affected. And we do expect a shift in non-white patients, and we are seeing that now. Some of that could be due to financial barriers. You know, they're less likely to maybe seek out care or get involved in research studies. So often these groups present with more severe disease. And there's also limitations of our studies that are not representative necessarily of the current population. And we are starting to see more perianal Crohn's disease in the African American population. And there's a new population of IBD out there. 20% of the patients are elderly. They're greater than 60 years old. They have long-standing IBD. And we've noticed that they don't get diagnosed. They've already had possibly microscopic colitis, but they don't get diagnosed for 6 years later because they really aren't having that many signs or symptoms. It's generally milder disease. And with this group, of course, with the comorbidities and the polypharmacy, there's increased risk of therapy-related adverse events in this population. Now, here is the inflammatory bowel disease, which we can see now is a global disease. It is all across the world. And this was before 1960, the one on the left. And it was lowest risk, as you're seeing, you know, by the light blue. And then on the right side, 1980 to 2006, look where it progressed. And the red is the highest risk. And you see the United States, Alaska, Canada there, and some of the parts over in Europe. So it definitely is increasing year to year. And here's sort of the epidemiological stages of evolution. And this was in 2020. And the green that you see over there in Africa, that they're starting to emerge IBD in that area. The yellow, there's an acceleration in incidence. And the orange, which you see there is United States, Canada, Alaska, et cetera, there's compounding prevalence in those areas, meaning it's just continuing to compound. So what are the potential explanations for this? The hygiene hypothesis, meaning we're so, clean, we're using, bacterial soaps and everything else. Infections can do it. Our westernized dietary changes with a lot of additives and all kinds of the oils and everything that's in our food. And then there's the microbiome hypothesis, our gut flora. So we don't really know the cause of IBD, but we do know that it is a complex interplay that's individualized to each person to cause IBD. And in the green box, you see that's the microbial antigens and adjuvants. The blue is an immune response. And basically what we see is an immune response where it's just gone wild. It's out of control. We keep on inflammation and it doesn't shut down. Then there's those environmental triggers. And then there's a genetic susceptibility. And so all of these compounding interplay together can cause IBD. So when a patient asks, is it my fault? Did I cause this? No, not you. You're not the bad person here. You're not at fault. It's a complex issue of many factors. So the genetic risk factors for IBD. So there's a vast majority with genetic risk that never get it. And it's not terribly inheritable at all. And that's key to let our patients know. About 10% of parents with Crohn's disease may have a child with Crohn's, and only 5% of patients with ulcerative colitis will have a child with UC. So this is really important to explain to the patients because some of them will say, oh, I don't want to pass this on. I don't want my kids to go through what I've been going through. So it's really important to talk to them about this. And then the other thing is, we've come a long way with this disease and we've got better meds and everything else out there. So important things to touch on with your patients when they're at childbearing age. And the hygiene hypothesis. So it's an incidence of immune-mediated diseases rising in developed countries. And the box over on the left, due to our modern hygiene, antibacterial soaps, our wipes, lack of exposure to bacteria in their lives. IBD incidence is prevalence highest in the Western nations. And an early childhood exposure to pets and being from larger families is protective. And you know that your pet in your house, you and your pet likely share the same microbiome. And the other thing, it's kind of like, don't totally sterilize your child's environment. They need to be exposed so that they develop immunity to these things when they're at a younger age, because it then becomes protective later on. So the individualized microbial landscape, 90% of the cells in our body are bacteria. Most reside in the gut. We're born germ-free. And the microbes that live in our gut come from the environment. Our infant diet, breastfed versus formula-fed infants. And we know that the breastfed, they're getting the immunity from their mother passed on. The hygiene, medications, our pets, etc. And then there's the genetic influence. Identical twins have similar bacterial communities. So diet and the microbiome here, I look at this and, when you think about our diet, a lot of our diet is really of convenience and not really health. Because our world, we're all fast, we're working, we're running, and it's like, get the fast food, get the, just whatever is easy is kind of how we are with our diets. So the large differences in the microbiome occur between regions and rural and urban areas. And you notice sometimes when you travel abroad or your patients do, and then they kind of develop symptoms and all of that, it's because they're eating a different type of food. It's different, and then they come back home and things settle back into place. Your high-fat diets increase the proteobacteria and Firmicutes, and they decrease the Bacteroidetes, which is the good bacteria. And the Mediterranean diet is better than eating a lot of meat and processed foods. They lower the levels of primary bile acids in the microbial dysbiosis in newly diagnosed Crohn's in particular. So variety of fiber is good, and there is soluble versus insoluble. And I know you're going to have a dietitian talk here later, try to talk more about that. But avoid emulsifiers like carrageenan or others that damage the gut lining. And that's the issue with these additives and dyes and all the stuff that goes into our food. So, and here was a study that was just published this year. And I thought it was interesting because it was in January of 2024. And it was all babies in Southeast Sweden and Norwegian. That was their mother, father, and child cohort study. And they followed them to adolescence. And they assessed the early life diet quality and food intake frequencies that were associated with IBD. And they compared the low diet quality medium, and low quality diet and the medium to high diet quality at 1 year of age. And what they found was that children at 1 year old, those that had a higher fish intake, their risk tended lower. Those who had a higher vegetable intake, their risk trended lower. And those that had a higher intake of sugar-sweetened beverages, their risk was higher, but they didn't see any associations between diet or quality at 3 years and later. So it's just novel findings suggest early life diet up to 1 year of age is important to later IBD development. And I also think in those areas, they probably tend to eat more fish and things like that than possibly we do sometimes in the United States. And the individual diet approach, remember, not one size fits all approach. There's not one diet that fits everybody. The factors to consider: your location of the disease, whether there's malabsorption in areas or not. If there's strictures, a history of obstructions, obviously, low fiber diet is better for those patients. They don't tolerate the high fiber with the stricturing. The fistulizing disease, the same thing: constipation versus diarrhea. When they're in a flare versus remission. When they're in remission, they can try more types of foods, maybe have more high fiber foods versus them when they're in the flare. And then there's that disordered eating group. And that some of that I feel is tied to patients who had strictures and they've been living with that. So they've totally drastically changed their diet. But after surgery and these strictures are gone and they can go back to normal eating, they don't because they're afraid to. So it's particular interest to watch these type of patients and remind them when they are not in a flare or the obstructions are removed, they can go back to eating and trying different foods. Here's an active disease diet. We usually say increased energy, focus on smaller, more frequent meals, and limit foods that may worsen symptoms. And those are all in the box there. Your high fiber foods can do it. There's your high fat fried foods. Caffeine and chocolate makes things run through us quicker. Alcohol, the carbonation is gassy. The sugar alcohols, obviously, and lactose. If they have a lactose intolerance, all those type of things are going to worsen their symptoms. Remission diet, again, we kind of say the Mediterranean diet. And high fiber, obviously, as tolerated. Olive oil is better. Limit and avoid red and processed meats. It can reduce flares in UC, but not relapse in Crohn's. Moderate intake: poultry, fish, dairy, wine. Again, moderation. And limit those ultra-processed foods, the salt, the sugar, and with all the additives in there. High fiber diet protective. Avoid overly restrictive diets, and optimize your nutritional intake while tolerated. So here are the environmental triggers of IBD. On the left, these are the things that alter our microflora, our microbiome. The antibiotics do that, and our diet, and all the foods that have these additives and all these artificial colorings and everything, flavoring, all of that. And then on the right, these are the factors that alter that mucosal barrier function, and they're involved in immunoregulation. Your acute infections, NSAIDs, we always tell our IBD patients to stay away from NSAIDs. Smoking, and smoking is particularly in Crohn's disease. And stress. All of these alter that mucosal barrier wall. And here's some of the lifestyle factors on inflammatory bowel disease. Obviously, sleep with inflammatory bowel disease. A lot of these patients, get up during the night or have pain, so they have sleep disturbances. So IBD in itself will do that. And sleep disturbances increase the flare. And this also increases fatigue in IBD. Then we have cannabis that may decrease symptoms, maybe the pain. But again, it can increase substance dependence, mood changes, etc. And there was another recent study that came out, and they said that these patients that are on cannabis, and particularly your younger kids, sort of get sort of relaxed and labile with the medications and following up. It's kind of maybe a false feeling like it's all great. So that's kind of like a double-edged sword there. The alcohol, no, there's not a lot of consistency there as to its effect on symptoms, but if it's carbonated, yes, more gas. But it doesn't increase disease complications. Smoking, again, increases flares in Crohn's disease, and also surgery. If they're constantly smoking, they're going to have a sooner risk of coming back to surgery. And actually, after surgery, smoking is the #1 recurrence factor in Crohn's. It can decrease flares in ulcerative colitis, but obviously we're not going to have patients smoke with ulcerative colitis because we know just smoking is a risk anyway. And so smoking cessation is very beneficial in these Crohn's disease patients. Physical activity can decrease flares, also good for surgical outcomes. And looking at about 30 minutes of physical activity in a day is what you would want to strive for. Obesity can increase flares, and obviously the medications don't work as well. They have to up the doses because of the obesity, and surgical complications go along with that. And then we have stress, the perceived stress, major life events, all of those things can bring on a flare. IBD is also increased with just perceived stress. And so stress management and disease activity definitely is a factor there. And I can tell you, even in my J-pouch patients, that stress will bring on pouchitis. And I see this often with some of the students, or just they have life events. The stress will bring on pouchitis in those patients as well. So what do we tell our patients to avoid flares? Strong recommendations: avoid NSAIDs in both, quit smoking, particularly in Crohn's disease, and adhere to prescribed medications. They need to continue to take their medications in order to keep themselves in remission. Modest recommendations: maintain vitamin D levels, exercise, as I said, greater than 30 minutes a day, and then the common sense recommendations with the exercise: get sleep, reduce stress, meet with a dietitian and nutritionist. I think that is very important, as well as meeting with a GI psychiatrist, mental health. We always need to ask and screen for depression, anxiety at every visit. And 50–60% of IBD patients with active disease have depression or anxiety. And they're not going to always bring it up to you. My mantra is just ask. You have to ask at every visit. So I'm just going to run through here a little bit on what are some of the clinical features of UC and Crohn's disease. You see, obviously, continuous inflammation. There's no patchiness there. It's continuous from the rectum all the way up. It can go to the cecum. Only in the colon, not in the small bowel. Superficial inflammation, meaning in the inner lining of the intestine, can be variable extent. As you look on the bottom there, the frequency of involvement, the darker areas are where it's most frequently involved. And obviously it starts from the rectum and the sigmoid and then moves further up and around. Risk of cancer in these patients and extraintestinal manifestations can also occur, the ocular, skin, and bones. And then in Crohn's disease, patchy inflammation. You may have disease up in the ileocecal area, but maybe they have some in the perianal area. Maybe they have a fistula or something down there. So it can be in different areas. It can be through part of the colon, part of the small bowel, but it isn't always continuous. So it's mouth to anus involvement, and it's full thickness. It's not just in the inner lining mucosa. It is through the intestinal wall. Fistulas and strictures can occur with this, and there is a risk of cancer in Crohn's as well. And again, the extraintestinal manifestations, the ocular skin and bones occurs. And as you can see with the frequency involvement with the Crohn's disease, it's most frequent at the the distal part of the ileum, the cecum ascending transverse, and then a little bit in the descending there. Those are the most frequent areas of development. So the other thing, is what is toxic megacolon in UC? And I know we see that somewhat, but boy, when I first started eons ago, we had 1 or 2 of these a week because we were getting patients from all over the country, thought they had irritable bowel disease. It's all in their head. They were crazy. They weren't getting properly treated or ended up in the ER just getting pain meds. So the disease went rapid, and here is what happened. And they get this huge, large intestines. And obviously, this is definitely a risk of perforation, surgical consult right away. But again, I used to see these all the time. It was just unbelievable because we didn't have drugs back then for them. It was just prednisone and, azolfidine. And then we were, experimenting with the 5-ASAs and things like that with research. So definition, it's non-obstructive colonic dilation of the transverse or right colon greater than 6 centimeter diameter, risk for perforation, urgent surgical consult, supportive at first, bowel rest, IV fluids, broad spectrum antibiotics, and definitely a surgical consult. Now, we do see one. I mean, I've probably in the last year, we sort of saw 2 that had come to us. And 50% of the time it can resolve with medical therapy if it's caught early, or otherwise they're going to need a colectomy. So the clinical features of Crohn's disease obviously depend on the location. Your ileocecal disease, you're going to see the abdominal pain, diarrhea, and fever there. And that's 40% is ileocolitis in the spectrum of IBD there. The colonic disease, bloody diarrhea, because it's the colon, they're going to have weight loss and fever. And colitis is about 25% of your Crohn's patients. Perianal disease, you're going to see pain, those fistulas on the bottom that are draining pus. They may have edematous hemorrhoids and fissures. And the rectovaginal fistulas, it's about 10% of women with rectal involvement. And sometimes, they feel that they're passing stool through the vagina because of the fistula. And then you have the enterovesical fistula, and they develop recurrent UTIs and pneumaturia, obviously. And you can see on there 5%, very small amount, do we see gastroduodenitis. And 30% is the ileitis and the jejunal ileitis there. So you kind of see the frequency there. Here's the phenotypes. There's 3 with Crohn's disease. You have the inflammatory, and then you have the stricturing, and that's the narrowing that develops, and they usually have bowel obstructions. And the stricturing a lot of times can occur from longstanding disease where they have the flare, then they go into remission, they lay down scar tissue, and this keeps repeating. And the scar tissue, gets more severe. Medication does not work on stricture scar tissues. We do know that. And then there's the penetrating phenotype, which are your abscesses and your fistula. And obviously, all 3 of these are considered severe disease, and the stricturing ones and penetrating, they're likely going to end up going to surgery for sure. Here's oral Crohn's disease. That's just chronic oral in ulcerations that occur. We usually put these patients on the magic mouthwash to hopefully heal up these ulcers and treat the disease. And then perianal Crohn's, this is about 25% of Crohn's disease patients. First, they may develop an abscess, because you can see a fistula from the rectal area to that pocket of pus. And then you have the fistulas, which are those dark lines. They track from the rectum out to the skin area. And then we also see skin tags in perianal Crohn's disease. And that's a common sign if patients have skin tags. And I always tell everybody, always look at the bottom. Always do an assessment on the bottom. The patients aren't always going to tell you they have these issues because they're embarrassed. And I always tell the house staff and everybody, always do a rectal exam and see what's going on, because you'll be surprised sometimes from what the patients tell you. Oh, everything's fine. You look down there, oh my God. Here's chronic perianal Crohn's, multiple draining fistula and scarring on the left. And you see those, that tissue buildup, those are draining fistulas, and that's excess granulation of tissue. You see the pus draining. On the right, that is more or less a single abscess there, a fistula tract. And you can also see the excoriation there from having a lot of diarrhea as well. Crohn's disease is a chronic progressive disease. You see there's preclinical signs before they're even diagnosed. They already have the disease. And the black is the inflammatory activity. And can you see it's going up and down? Where they go into a flare, they go into a remission, and that continues. The blue line is the damage that is occurring, the stricturing. They develop the fistulas and the abscess, they end up surgery, and then they have stricturing again. And so the highest potential for response to therapy is going to be early on in the diagnosis. And that's why it's so important to diagnose these patients early. The lower potential to respond is when they get to the stricturing and you're going to surgery, obviously, up there. The extraintestinal manifestations of IBD, I'm not going to go through every one of these, but you see the oral ulcers, the C down there, the erythema nodosum along the legs. And then we have the pyoderma gangrenosum there in D, which looks horrendous when you really see it. It's got this bluish tint to it, open ulcerations. And the one below that is E, the peristomal pyoderma gangrenosum. And I have to say, we're seeing that a little more these days. And often I'll see that if the rectum is left in place, because it's either a staging procedure or they were too sick, they just needed to be diverted before they could take the rectum out. Often that remaining rectum actually will feed this process and keep that pyoderma gangrenosum going on. Once we remove the rectum, oftentimes then the disease is gone and it's not bringing on the pyoderma there. You see the eye issues, uveitis, and the episcleritis there in F and G. And then, of course, all the spine issues, the arthritis and sacroiliitis and all of that we see in these patients. And here just shows in the green, those are more frequent extraintestinal manifestations that we see, and the blue are more rare. And often they do get better when they're, treated and the disease is under control. So it's caused by an immune response to an increased antigen load in abnormal bowel mucosa. It's an autoimmune response, which increases with foreign protein or bacteria in that intestinal mucosa. Predominantly, it's in colonic disease. There is a role of genetics possibly there. And treating the underlying IBD often improves or resolves these EIMs. But the exceptions are the ankylosing spondylitis, uveitis, and primary sclerosing cholangitis. Those usually do not get better if the disease is under control. And of course, you all know the expanding role of biologic agents for treatment. Many of them were already being used in rheumatology and in dermatology, and we also now use those in the treatment of IBD, so they do a dual role here. And the other thing, assess for them at every visit as well. So another piece that I want to talk about here is the urgency. That's a symptom that got newly codified into the ACG guidelines this year. And here are the clinical features. Those that are more common in ulcerative colitis is your diarrhea, rectal bleeding. And then in Crohn's disease, your more common one is the fevers, abdominal pain, weight loss, and signs of malnutrition, as well as growth failure in children. But here's urgency that's newly added on. It's more common in ulcerative colitis than it is in Crohn's. And so why are we asking about it? Why is it important? Because it really is the most burdensome symptom of ulcerative colitis, that feeling of urgency and gotta go all the time and going to the bathroom, and sometimes there's nothing there. And a single accident, leaves an impression with them that they're so afraid, they've soiled their underwear or they had an accident out in public. And therefore, they kind of fear of going out, socializing, doing things, living their life. They sort of can become a prisoner with this. So this sort of shows where disease severity versus bowel urgency study. And this looked at 200 patients, and they found that 35 of those that were severe, 62.9%, which was 22, had severe disease reported bowel urgency. And those with moderate to mild, 42.9% of those patients reported they had bowel urgency as well. And we now have an urgency scoring scale from no urgency to the worst possible urgency. And you ask the patient, how severe was your urgency? The need to have a bowel movement in 24 hours, and you ask them to score that. And it's a pretty distinct symptom of ulcerative colitis. And the scoring correlated highly with the global rating of severity scores and moderately with stool frequency. So urgency can still persist despite bowel symptom or endoscopy improvement. The persistent rectal inflammation, when that's there, the rectum doesn't stretch, store, or squeeze as it should. Patients are embarrassed, don't want to discuss it, don't want to talk about it, may downplay it. So that's why it's important to ask. It decreases their quality of life, obviously. And what's important to ask, what does urgency mean? Because they can say different things when you ask them. Like some will say, well, it's incomplete emptying, meaning they're going and sometimes nothing comes out and sometimes it does. So that's urgency to them. Or leak of stool. Like every time they have urgent, there's a leak, or that pain, that spasming in that anal area. So you need to understand, from the patient, what does urgency really mean to them? And does it disrupt their life? Obviously, getting up at night, not being able to go to work that day. They're afraid to socialize, and they avoid sexual relations. So very important to discuss and talk with our patients. And again, it was newly codified into the ACG guidelines for ulcerative colitis.